Now, I would like to briefly introduce our speaker, Dr. Michael Sells. Dr. Sells is the Public Health Advisor on Advancing Population Health Team at the Center for Disease Control. Dr. Sells, you may now have the floor.
Thank you, Samantha. And I'd like to take this opportunity to also thank the planners and the chair committee for this great conference on health justice. This is a great opportunity to speak to everybody. And I look forward to interacting with you guys. And I also want to take this opportunity to give a quick shout out to my niece, Alexis Sykes, who's in the 2021 graduating class of Upstate. So we'll get started. So today, I'm hoping that at the conclusion of this presentation, you would gain a really great understanding of how important addressing health disparities and the social determinants of health are in your specific context. Also, I'll take the opportunity to kind of describe CDC's approach and how we work and collaborate with health systems and clinicians and providers. In addition, I'll talk a little bit about some examples from a public health perspective and examples of how those collaborations happen between CDC and health systems, as well as I'm going to bring it home a little closer and talk about some of the important cultural and cultural considerations that we need to make, and also kind of stress the importance of cultural competency and how we must engage the community. So I'll start off with some important definitions that I feel that we all kind of need to have kind of a common definition so that you understand sort of where I'm coming from when I talk about health equity, health inequities, health disparities, social determinants of health, and other factors like psychosocial stressors, as well as socioeconomic stressors, discrimination, and racism. So when I'm referring to health equity, it's the common definition defined as being achieved when every person has the opportunity to attain their full health potential, and that no one should be at disadvantage from achieving this potential because of their social position or other socially determined circumstances. Now, health inequities, as stated on the slide, are demonstrated in differences in the length and quality of life, rates and severity of disease, rates of death, and access to prevention and treatment. Health disparities are the things that we can measure, the measurable differences in health outcomes. And social determinants of health, the conditions in the environment in which people are born, live, learn, work, play, worship, age, that affect a wide range of health, functioning, and quality of life outcomes and risks. I'd also like to talk a little bit about some of the other factors, as I mentioned. So psychosocial and socioeconomic stressors. These are those negative factors such as low socioeconomic status, depression, job stress, financial stress, segregation, segregated neighborhoods, and neighborhood poverty level, as well as things like discrimination. So discrimination is this unjust or prejudicial treatment of different categories of people or things, especially on the grounds of race, age, or sex. And then racism. I like to use Dr. Kamara Jones' definition of racism because it provides it from a great public health context. And so her definition says that there's a system of structuring opportunity and assigning value on phenotype that unfairly disadvantages some individuals and communities and unfairly advantages other individuals and communities. And this undermines the realization of the full potential of the whole society through the waste of human resources. So now I'll switch gears a little bit, and I'm going to talk to you about the specific work that I'm involved with in the Division of Heart Disease and Stroke Prevention at CDC. So this is just an example of our organizational chart. I work in the Program Development and Services branch. We have an Applied Research and Evaluation branch, as well as an Epi and Surveillance branch. And I like to really be in the area where I can translate research to practice, translate science to practice. So I like also having the opportunity to work closely with states, communities, and kind of have an opportunity to kind of be on both sides of the equation. So in my branch, we have uh, these core focus areas. So our branch, which is the Program Development and Services branch, works closely with state and local health departments, national public health organizations, as well as health systems. And here are the focus areas. And you can see, for those of you who are clinicians and providers, you can see that there's some connection here in terms of clinical measures, uh, clinical services, and linking community resources to clinical services. Here are some examples of specific strategies that we address within our division that we focus on trying to raise the awareness of physicians around the need to really monitor blood pressure, as well as cardiovascular disease, and also cholesterol. And we also partner with our Division of Diabetes Translation Department. So you also, next slide here is a slide of the United States. And what you see are a series of programs along the side here. And these are all the programs that our specific branch and division partners with, funds, and collaborate with across the country. So we actually, the heart disease and stroke, we partner with every state in the union, as well as we work with some U.S. Pacific Island and U.S. territories. So as you can see, we span across the whole country. And there are also specific programs that are directly targeting health, trying to reach health inequities, trying to eliminate health disparities. And that's where kind of I'll go throughout the remainder of this presentation. So how do we think about and how do we address health equity within CDC? There's this common approach that you can create a program and it can be general, and a rising tide will lift all boats. So you do this program, you perform these interventions, and basically you should see results across the board. So it's either doing that or you take resources and you divert them and you target a specific population who's facing disparities. So that's been kind of the struggle that we've been faced with kind of on the federal level, kind of, and also on the state level sometimes, that we tend to feel like we need to either do this way or do it that way. But what the approach that we implement in our division is what is called a dual approach or targeted universalism, where you do both. You allocate resources to address the entire population, but you also allocate resources for specific efforts that will reach those populations who need more help. So that's the approach that we try to follow. When it comes to the social determinants of health, we believe that all sectors are there making decisions in areas that are important for public health. And by bringing them to the table, we add value and we get unique skills, expertise, and points of view. Also, we would create a win-win scenario, and this ability to also more effectively leverage our funding and our resources. So, and it also results in a buy-in across the board where we may result in critical and sustainable changes. And as the slides say, we definitely look at this from a multi-sectorial perspective. Examples of health equity focused cooperative agreements. So cooperative agreements are the vehicles that we use at CDC to fund and collaborate with state and local health departments, community-based organizations, as well as health systems, international projects, etc. So these are some examples of the ones that specifically focus on health inequity. So we have the Wise Woman program. We have the Innovative State and Local Public Health Strategies, which is a collaboration between our division, Heart Disease and Stroke, and the Division of Diabetes Translation. And we also have the Good Health and Wellness, our GWIC program, which focuses on the tribes. There's a project called the Mississippi Delta Project, the Delta Initiative. We'll talk a little bit about that more as I move along in the presentation, as well as some of our national organizations and partners, such as the American College of Preventive Medicine. So here is the WISE Woman program. The focus here is on low-income, uninsured, underinsured women between the ages of 40 to 64 years. And the focus here is on addressing those risk factors, doing screenings, as well as health behavior and support services that will result in healthier outcomes. And as you can see, we fund 30 recipients in 27 state health departments and 3 tribal organizations. The next example program is the one that I mentioned earlier, the Innovative State and Local Public Health Strategies. This is a collaboration between our Division of Diabetes Translation and my Division of Heart Disease and Stroke Prevention. Again, we urge our subrecipients and our recipients to think of innovative ways to reach at-risk populations. And you can see here that we fund 29 recipients, and those can be both from state health departments as well as from cities, well as from large cities. And here are some examples of some of the strategies that we implement, where you can see the wording is kind of small, but I just wanted to get this here so you can kind of see some examples of how we urge our partners in the health systems and the health departments to focus on clinical measures, focus on team-based care within clinics and health systems. Look at how community resources and clinical services can be linked. The next slide I'm sharing here is talking about the Good Health and Wellness, our GWIC project. And this is our largest project that seeks to reach American Indian and Alaska Native projects. And here we fund approximately 27 programs, and it's been around a while. And as each funding cycle concludes, a new funding cycle begins, and we build off of what we learned from in the previous cycle. And just here are some example strategies and activities that we would that our partners in the tribes are implementing, ranging from engagement of community health representatives. This will be equivalent to community health workers. Also implementing team-based care and ensuring that physicians have support from their non-physician team members and ensuring that everybody's on board. And then the most important piece is the culturally appropriate materials, strategies that we work with the programs to implement. So our next slide is, the next program that I mentioned here is the Mississippi Delta Project. So many of you probably are aware of the stroke belt. And so Mississippi is a part of that stroke belt. And there's a specific area within Mississippi, and I'm sure some of you may be aware of, called the Mississippi Delta, where there are numerous health inequities, health disparities, and folks there really need a lot of assistance. So this project seeks to collaborate with those, with the state in that specific area of Mississippi. And it creates, as it states, a bridge between the patient and medical services. And you can see also that there are 3 specific program areas. We, again, working on the clinical side, working with the community, and for the purposes of this particular project, faith-based organizations play a critical role. Finally, I'm going to talk about the American College of Preventive Medicine. This is a partnership with one of the national partners who are are funded to work with two projects. They support work with African American men. And so we're trying to work with them around how we can effectively address the population who is bearing the highest burden when it comes to cardiovascular disease and hypertension. And also, this project will result in a population health integration curriculum that will be rolled out broader once we've tested it and found it to be effective. So now I'll switch gears and talk a little bit about CDC's COVID response. I'm currently on loan, or I've been pulled from my current role in heart disease and to now working in the COVID-19 response. So within the response, there's been a COVID-19 response health equity strategy. So I'm a part of what is called the CHIO team, or the CHIO unit, the Chief Health Equity Officer team. And and let me just talk a little bit about the health equity strategy, because I think that's the important piece here. So this strategy broadly seeks to improve the health outcomes of populations who are disproportionately affected by COVID-19. And we have four major priorities in which we do this. And we work within CDC, within the response, as well as with our partners on the state and local level. So our charge in this unit is to basically coordinate with the other task force across CDC, as well as coordinate with our state and local partners. So as you can see, it's we really want to try to ensure that specific populations get the attention and the resources that they need. So I'm going to take some time to discuss some practical approaches that we should consider as clinical and public health practitioners. First, there's tailored policy systems and environmental approaches, which are considered broad scale, sustainable, and potentially scalable. Also are needed to promote continued change within communities and to establish communities as places of opportunity for health and prosperity for all. So one issue that I really like to focus on a lot when I'm presenting around health inequities is to stress the need for tailored interventions. So not just the typical approach as a kind of a cookie cutter approach, but the need for us to look at the populations, the patient population that we're serving, and consider their cultural things that make them unique, as well as the individual qualities that make them unique, and tailor our approaches or our interventions to meet their needs. Next, within this need for us to tailor approaches would be regarding policy changes. So policy changes are changes within our organization that we need to make, as well as changes that are external facing. So there may be a need for us to change a policy when we realize that our patient population is becoming more Hispanic, more, they may speak another language. So we may need to change policies in terms of the signage or just the way we communicate, ensuring that we have people who can speak multiple languages, just different policies that we need to change in order to accommodate the populations and the communities and patients that we serve. The next item would be community engagement. It's always important to understand and have empathy for the communities that we serve, because it's easy to tell when someone is not genuine. And it's much more effective when you are genuine, truthful, and honest, and you are committed to the community. So the need to engage communities is an important aspect that we must consider. So as providers and practitioners, we have major roles to play in efforts to eliminate health inequities. So we should collaborate on multiple levels. We should embrace cultural competency and diversity. We should address biases that we hold. We should avoid stereotypes. We should be willing to implement tailored approaches. And we should acknowledge that our patients are human beings, despite their circumstances. They're human beings with feelings, emotions, and they want to be well. They want a great quality of life. No one wants to be in a negative circumstance. No one wants to be sick. No one chooses that. So I'll now talk a little bit about cultural competence and talk about it from a continuum perspective. So in our communications and interactions, cultural competence is an important factor to consider when communicating with persons or patients from diverse populations. We will cover 5 stages in the cultural competence continuum. And these stages are cultural destructiveness, cultural incapacity, cultural blindness, cultural precompetence, and cultural competence. So cultural destructiveness is where people actively belittle other cultures. Cultural incapacity is where people show no interest or appreciation of other cultures. Cultural blindness is where people treat all cultures as if they are the same. Cultural precompetence is where people have acceptance and respect for differences, and they continue to kind of look within themselves, with self-assessment. And then finally, there's cultural competence, where people unconsciously hold culture in high esteem and use this to guide our lives and our work. So, in terms of the cultural competence continuum, there are assumptions that must be considered across these continuums. So, for example, cultural destructiveness. We deserve this is the mindset that one may have. This is only our way and it's the right way. So you either do it our way or you can do the highway. And this is often considered a way of forcing assimilation. And the rights and privileges for only the dominant group are what you consider to be the right way to do things. Next, there's cultural incapacity, where people choose not to be a part of the process. This is just the way we do it here, so this is how we're going to do it. We're going to have these expectations for how, that's in our mind, and also these stereotypes that you might have for folks are maintained. And then I want to just say a little bit about cultural blindness. And these are the folks who say, I don't see color. We're all just the same. Just give me a checklist so that I can say I was in this required training around cultural competence. So we go from there to cultural pre-competence. Let's just hire an expert. This is the folk that say, just teach me what to do. I don't really have time to embrace this, but I know that something needs to be done. And then we have cultural competence. This is where you say, let's work together to truly empower our communities. And this can result in those policy changes that I mentioned earlier. So in terms of the cultural competence continuum, now I want to switch and talk about power dynamics. This is a critical piece when you think about it from the perspective of us being public health practitioners and providers, and how we interact with our patients and the populations that we serve. So there's cultural destructiveness. Again, this is from the power dynamics perspective, where you may know that you need to do something, but you hold a meeting during a time of day when you know that maybe the folk that are most impacted by the decisions you're making can't make the meeting, and you don't accommodate them. Or you say, well, this is English only approach. If you can't speak, if you speak Spanish or whatever, that's your problem. This is America. So these are this kind of way you you're being destructive to the cultural needs of folks. And next is cultural incapacity. This is where you may conduct a traditional town hall model. And it's this strange mentality here is where you have this bootstrap mentality. I made it, they should be able to make it, not considering other factors that may be at play, which, can be social determinants of health and things like that, or discrimination or racism. Next, there's cultural blindness. So this is where, you may know you need to do something. You hold a festival, and you give this group a booth or something, or you do some translated newsletter. These are things you can just check off, but actually, are they really effective in addressing the needs of the populations that we're trying to serve? Cultural pre-competence. This is where you make a decision that you need to do something, and you really want to commit something, to this process. But what you may not do sometimes, what you might do is consult with somebody, or you may hire a member of an ethnic community to come in and serve as an expert. But there isn't really no real sustainability, because that person will leave once the training's done, and there's no real buy-in. Next one is cultural competence. And this is where I like this example where a Native American art and storytelling project is rolled out. And for this to happen, you had to have Native populations involved from the start to the implementation to the conclusion. And so this is a great example. And also, others I like to talk about are things like the trusted advocate model, where you share power, and also community-based participatory research, which is an effective approach that I've seen and I've been a part of here at CDC. So meaningful engagement. Community engagement must be meaningful, especially when addressing health inequities. Meaningful community engagement with those most impacted by health inequities can potentially result in the following positive outcomes. So what I have on the slide, when you meaningfully engage the community, it will result in changing existing power dynamics, better understanding of what people are faced with, creative solutions, because now you have folks who are at the table who bring various perspectives that we may not have considered. You have an increased buy-in and support, as well as trust, which is an important aspect that we definitely should always consider. I'm coming to the conclusion of my slide. So one other thing I want to just mention here are the goals and benefits of racial and culturally appropriate community engagement. So here I'm just, in terms of some major goals you may want to consider as you engage the public or the community, is that there's a need for us to ensure that we empower communities to make decisions for themselves, release the capacity and potential of those communities, and change relationships between us as providers and the communities. And so the results that we can find there are better quality and responsive services, reduction of the inequalities and inequities that we've seen, and you'll see a greater ownership in the populations, patient populations that we serve. Because now they understand that you really are looking out for their best interests. And they, again, as I stated earlier in the presentation, everybody wants to be healthy. So the last item on the slide just says better understanding why and how services need to change and develop. So across the board, everybody has a better understanding. So I'd like to conclude real quick with a brief story. So during the time when I was really looking for what I believe to be my calling, I was led to the field of public health. So I had the privilege of joining a fellowship program in 2001 at CDC. And at the time of this fellowship program, I was invited by Dr. Bill Jenkins, who is a whistleblower for the Tuskegee syphilis study. And so he invited me to attend a memorial event for the victims and survivors of the Tuskegee syphilis study. So at this time, I had the honor of meeting the person pictured in the newspaper clipping, Mr. Ernest Hendon. And he was the last survivor of the Tuskegee syphilis study. And he was present at this memorial service, as well as the families and loved ones of the other men who were victims of the Tuskegee syphilis study. So at that time, not knowing that Ernest would not live much longer, I made a commitment. I made a vow to always never forget them and to commit my public health career to the elimination of health disparities and health inequities. So um, I always at times like to conclude a presentation by acknowledging this gentleman and acknowledging those survivors, and also with the realization that this was not the only incident. There are many others, and these are still fresh in people's minds because, as I stated, these men who were in the Tuskegee syphilis study are their family members, friends, and loved ones are still alive, and it's still fresh in their minds and in their hearts. So I want to thank you guys, thank everyone here for this opportunity to present to you. I see that I went a little faster than I expected throughout my presentation. Uh, and actually I went faster than I practiced. So it allows us, I guess, more opportunity now for maybe some questions. And now I'll just turn it back over into the hands of my sponsors here. Thank you so much.
Thank you so much for that incredible presentation, Dr. Sells. I really appreciated the cultural competency continuum. So now we have about 20 minutes for questions. So our chat monitor, Angeli, will be reading questions that we've received from the chat. If you also would like to unmute yourself, just raise your hand and then we will request to unmute. Again, we have about 20 minutes for questions.
Thank you. And thank you, Dr. Sells, for that wonderful talk. Um, the first question we have, um, are students or residents allowed to participate in the Mississippi Delta Health Collaborative work?
Yes, if let me say this. So if you are in that area of the country, in any of the projects that I mentioned, and you are involved in any of those hospitals or working in any of those sites, you're definitely welcome to present. I mean, to participate. It would be a matter of reaching out to the and I think for that one, I think it's the Mississippi Health Department.
Thank you.
Mhm.
Um, our next question is, um, how can we promote our medical, I apologize, how can we promote our medical programs in other institutions that we are part of to transition from cultural pre-competence to cultural competence?
So that takes efforts on. I often talk about multiple levels. So that takes efforts from leadership, and it takes efforts from those who are the staff and the workers. So um, bringing it to the attention of your leadership, and also acting on it yourselves is, I guess, the best way to do that. I often say, and often just from my own experience, I haven't always been in leadership roles, but I've always pretty much performed according to the ethical beliefs that I have, as well as I follow the science, and I just believe in doing the right thing, and eventually, if it's the right thing, it will prevail.
Thank you. And I think a good follow-up question for that is, how do you suggest we respectfully challenge those faculty, administration, curriculum committees to better design curriculum to address the topics discussed in the session so that the information is meaningful and makes a difference as we as students can make the changes needed to serve BIPOC individuals in the way that they deserve? Are there any resources you suggest we look into?
So, first of all, because you're all students, and I now have college age children, and I just had a conversation with my youngest son, and I was like, man, it's going to be on you now. You're going to have to take the baton and mend a lot of these issues that we're facing. I didn't say it like that to him, but to respond to your question, I would say become as educated about the issues, about the specific programs and innovations that you can. So there are lots of great organizations and scientists out there who are publishing and presenting around these issues of health inequity, health disparities, how to, there's one issue that I'm not really an issue, but an approach that I'm really focusing on right now. It's called intersectionality, where you look at the um, relations between all various risk factors and how one specific population is just maybe hit with a series of risk factors in comparison to another, and how these risk factors intersect to result in all of these health inequities. So I'm saying that you as students embrace what's out there, embrace the science, and follow the science and hold folks accountable to what you know to be true and what you know to be evidence based. So there are evidence based approaches that folk may not be aware of or may be aware of that they ignore. I would say that you become aware of those approaches and hold your leadership and you yourselves accountable to performing those activities.
Our next question, how do you include the public in your work so that they can begin to acknowledge and understand the presence of health disparities in our communities?
So, great question. I arrived in CDC, and I was after my fellowship, I was hired to work in the racial and ethnic approaches to community health program. And this program specifically targeted community based participatory research. So, to answer your question, my first response would be to follow the strategies of community based participatory research, and also to think about ways that specific key stakeholders, gatekeepers, and leaders who are experts in this area can be engaged in the work. And then you become one. So yeah, my response is always don't don't shrink to the situation that you're faced with. It's easy to shrink and think that somebody else will do it. It's easy to shrink back and think that, oh, I'm just I'm a first year, or I'm just I'm just a graduate student. Uh, Nobody can, I don't have any power. Yes, you have power. You guys have more power than I had when I was your age with the social networking and things.
Thank you. Um, as students, what do you recommend are the steps to take to make institutional changes without creating a target on ourselves? I think that's a good segue.
Yeah, yeah. So I would say this, that um, work as a group. That way, you're not one person out there being the lone voice, and you have that target that you are referring to. But work with folk who have like minds and like interests, and like passions, and understanding that something needs to be done. So um, that's my response there. Don't put yourself out there like that. uh, Work with folk who are like minded, and you guys speak as a unit.
Um,
Good questions.
Have you
Good
seen
questions.
have you seen any personal victories in recent years in changing the current climate of health disparities?
Okay, so you remember now, look behind me. where is it? Right, wherever it is. I'm speaking now as a CDC employee. So I can't. I don't know if I can respond to that question. Not in the capacity that I am speaking. If I was speaking as just Michael Sells, I probably could respond. But working and speaking on behalf of CDC, I don't think I can respond like I want to.
We have what advice or insight can you offer to hospitals or health systems navigating the understandable fears or suspicions vulnerable populations might have about receiving the COVID-19 vaccine?
Ooh, that's a good question. So um, because that topic and the the guidance from CDC changes almost on a daily basis, I'll respond, but I'll say I'm responding from our current knowledge, and then from Michael Sales' perspective, uh, and not CDC. So um, this whole issue of vaccine um, hesitancy that we're seeing and how that is a major issue amongst populations who are actually the most at risk right now. So the way that I believe in and I'm trying to promote is to get buy-in from key community leaders, get support from key community leaders, faith-based organizations, um, and individuals who look like the folk who have concerns. So to me, that's the approach that I'm trying to promote now. Um, it's much easier for me to hear from somebody who I trust from my community first. Second, from somebody who might look like me, who is credible. Second, and then somebody who is credible and proven and who are following the science. So those are the really three major uh, criteria that I want to try to follow as I do the work that I'm doing. Now, what we're also seeing is these alternative facts, and that's a major challenge that we're faced with. So even though there's science and we're trying to do this thing as evidence-based as possible, there's this challenge and kind of this uh, tug of war between what's real and what are the scientific facts and what are fake kind of, I don't say fake news, just fake facts that are much more broadly spread and also broadly believed. So it's kind of a major challenge that we have.
This next question is from an Upstate faculty member. When looking to engage with the community, another group to look for, in addition to community-based participatory research, this might this might be a comment.
Okay.
Yeah, in health systems, it is sometimes called patient engagement in research or patient and public involvement. Look for the researchers who are funded by PCORI, Patient Centered Outcomes Research Institute. She meant, or he or she mentions this as a doctor in public health and the director of the University of, I believe, South Carolina Patient Engagement Studio. Multiple
Awesome.
terms are used for similar concepts.
Great. Yeah, there are tons of partners out there in organizations. And a lot of times, because I'm in public health, I may not be aware of all of the clinical opportunities and clinical partners. So I'll often, actually, South Carolina is one of the states that I'm assigned to work with. And so I would defer to someone from South Carolina who is a part of staff and faculty at maybe University of South Carolina to to kind of assist in some of these areas.
I was, wondering if you could also maybe respond to this comment and let us know what you think. Someone in the chat wrote, I wish cultural competence in education wasn't just a box to be checked, but rather a key factor or core value interwoven into our education so we can be effective, compassionate, competent providers to our patients. As stated in another session, faculty must understand racism to be able to effectively teach topics such as this.
I agree. And I'll say um, it's for me working on a federal level. Um, Depending on the administration that's in control or in power on the federal level, we are often, it varies. You'll see based on who's in leadership or who's in power, how we can react and act on some of these sensitive topics. So addressing racism and discrimination was not popular in this current administration, but I think that the restraints will be lifted for us on the federal level to really dig deeper into this in the near future. So I'm very excited about that opportunity. But as the person stated, yeah, we have to uh, acknowledge institutional, systemic racism and how all of these things are factors into the health outcomes of our patients and our communities.
I think we have um, maybe one or two more questions. Um, how can faith-based communities or partnerships assist in creating a more equitable medical and healthcare field?
So that
I'm sorry, medical and public health field.
Okay, no problem. So, with some of the projects that I've worked with in the past, faith-based organizations have served many roles. So, first, faith leaders are great advocates and supporters. They are a lot of times the gatekeepers and uh, the key the leaders that we need buy-in from, and they can be the voices of public health and of healthcare, but also faith-based organizations. As many of you know, many of our ethnic and racial populations are um, they're strong in terms of their involvement in faith-based groups and their beliefs. So getting buy-in, getting support from faith-based organizations is an extremely important factor, especially like I mentioned the Mississippi Delta Project, some of those Southern projects, and just getting them to sign off on our work and support it and providing them with resources that they need to better serve their congregations is kind of this um, dual strategy that we must consider.
One more question. Should cultural competence in policy agendas and implementation be more tightly integrated into the mainstream SDOH model? Do you think this could generate greater cultural competence or have adverse effects in encouraging cultural blindness?
No, I'm always for uh, advocating on behalf of cultural competence. Um, yeah, so there's always going to be the naysayers, there's always going to be the late adopters. But in order to address the social determinants of health, you have to you have to immerse yourself into the environment. And so there are going to be cultural components that you have to consider when you talk about where people live, where they work, where they worship, where they go to school, where they play. Um, and all of these have to, cultural issues and cultural factors have to be considered. For example, one group may be more into soccer, whereas another group may be more into football. And so if you're trying to engage them in physical activity and you go to this group and you talk about Let's create some football fields and places where folks and youth can play football. And they're like, no, we're really into soccer. You're losing the cultural connection there. So that's the example that I would kind of provide there.
Thank you so much, Dr. Sells, for this incredible presentation. And thank you to our audience for such incredible questions. I really liked understanding, the rationale of vaccine hesitancy and maybe why that's happening in certain groups, comparing it to groups who have a history of exploitation by the American medical establishment. But thank you again so much. Thank you for this incredible audience participation, incredible questions. Thank you again, Dr. Sells, and I will see you all back at 12:30.
Thank you guys. Have a great day.